welcome everyone. Bienvenidos. So excited to have you all here. My name is Dr. Eliana Ramirez. I'm the director of the CARE TA Center. I'm here with my colleagues, Dr. Danny Soto and Ande Peña. We are thrilled to present the second installment of a learning collaborative on justice diversion. So our typical disclaimer, we are so grateful for the funding from the California Department of Healthcare Services and CARS, which provides us administrative organizational support. What we're about to share here does not necessarily represent the opinions of anyone besides ourselves. In the very unlikely event of a interruption, if we needed to, for security issues, we would close the Zoom room and open another Zoom room and send you a new link. But hopefully there won't be an issue, but just to let you know, if we did need to close this down, please check your email. So what is CARE? CARE is the Crisis and Recovery Enhancement TA Center. We are funded through the Mental Health Services Act to provide training and technical assistance across the state of California, primarily to the 58 MHSA funded counties, as well as the 2 city jurisdictions in the state. We strive to address behavioral health crises in the community, keeping people outside of institutions like emergency rooms, locked psychiatric facilities, jails, and prisons. We provide no-cost TA. We are thrilled to be part of a robust collaboration. You can see many of the organizations who are collaborators here. Dr. Soto is part of Impact Justice, so it's really wonderful that she is here with us today. Our work involves many types of TA, training and technical assistance, all at no cost. You can learn more about them by going to our website. Just want to highlight 2 brief things to you. 1, our second conference is coming up. Don't miss it. It's going to be on May 25th. It's entitled Keeping It in the Community. And we're all about focusing on crisis care in the community with hope and action. Also go to our website where you can find more resources in our resource library and an asset map. As I mentioned, today is our second learning collaborative series on justice diversion. Today, we have focus on evidence-based and community-defined diversion practices. Our next learning collaborative is going to be focusing on justice diversion evaluation. And it's really exciting to think about these 4 learning collaboratives are building upon one another. So our first learning collaborative was looking at the sequential intercept model and intercept stages of justice diversion. Today, we're taking a deeper dive into that SIM model, SIB model, by looking at evidence-based practices. And the third session that's focusing on evaluation, Dr. Soto is going to take us even further down to, okay, now that we've talked about the SIM model and EBPs, how do we actually evaluate that from a diversity, equity, and inclusion perspective? And then our 4th and final session is going to be looking forward. How do we sustain the justice diversion systems change work that we've talked about over the course of these 4 sessions? I am honored to work with the colleagues who I will present with here today, and I'm going to invite them to introduce themselves in just a second. Just briefly, I'm a social worker by profession. I've spent most of my work with LGBTQ communities and veterans and communities of color. And it's really exciting for me to be here with you as the director of TA Center. I'm going to invite Dr. Soto to introduce herself.
Hi, everyone. Welcome, and thank you for joining us today. I'm Dr. Danny Soto. I'm the Associate Director of the Research and Action Center at Impact Justice. I am a researcher by trade and training, and I definitely see my role as a supportive one, supporting all of the important work that many of you are doing in providing services and supporting communities. So I'm excited to spend time with you all today. And I'll pass the mic to Ande.
Hello, thank you. My name is Ande Peña and I work with the CARE TA Center. I'm extremely happy to be here today speaking about one of the subjects that I care a lot about, justice diversion. My experience has been working with young people and adults that are impacted, mostly those that are in either the reentry stage and or the court diversion stage. And so I've worked with the treatment courts and I've worked under probation contracts, providing services in the community. And I'm excited to be here today. Thank you all for joining us.
Thank you, Ande. And thank you all so much for answering those questions. It's great to hear who's with us and what your baseline understanding of some of these topics are. We really welcome you to please share in the chat box as we move through this training perspectives that you have, because it's clear that many of you have a lot of expertise in this area already. So please do join us and contribute. So today, in addition to reviewing the SIM, we're going to talk about the crisis continuum of care in relation to justice diversion, followed by operationalizing the idea of evidence-based practices at each intercept point of the SIM. And we will be considering that while EBP, evidence-based practices, is a term that's thrown around quite a bit. It's used when we apply for funding. It is used in our notes, our clinical notes, which are really important in case there's ever a question about our practice. It's also used because we really want to make sure that what we're doing with clients is actually helping them, right? And we want to use interventions that are based on research that tells us that there's some reason to think that that particular intervention will actually help out. It's a complicated issue though, because evidence-based practice, while it's a term that's used pretty frequently, is actually something that is not very well defined. In fact, SAMHSA, from the National Registry of Evidence-Based Practices, at one point was changed. It was taken off the website because there is so much discussion about what constitutes an evidence-based practice. It's actually pretty complex. Who is it that we are doing our research with to establish efficacy of an intervention? Are we testing out our practices with people of color, with LGBTQ folks, with people from various other social backgrounds? And to what extent are we implementing these interventions with fidelity? So I just wanted to start off with this idea that we want to always attempt to do the most good with the least amount of harm. And that's why we focus on evidence-based practices. But today we're actually going to unpack it a little bit into the realities of what it means to choose an EBP and implement it. And then finally, we'll conclude with providing some resources related to evidence-based diversion practices.
Resources throughout the presentation, you're going to see a little icon that looks like a scroll, and that scroll is going to indicate that there is a resource located on the handout that you received in your reminder email. We'll also add it in the chat and we'll add it to the follow-up email, but there are resources that connect exactly to the content that you're seeing on the slide. We did ask you to look at your county and to go through the intercepts. There's a model here from SAMHSA's Gain Center that you can see on your screen. And what we wanted people to do was to go through their county, go through the intercepts and kind of see where were the intercept points that had heavier concentrations of services. Where were intercept points where maybe there was a gap in services or fewer services. The other question that we ask people to look at is what populations may not be served by the existing services. And then that gives us the ability to respond to that gap or respond to the population that is in need of additional services and supports. And then lastly, we asked you to please describe any staffing or funding or other logistical challenges that you might have faced that created barriers for you in implementing specific justice diversion services in your county. So those are the things that we will bring into the discussion point when we do our cross-county sharing. And in the meantime, what I wanted to do is I wanted to share a reflection that came out of Fresno County and Fresno County's experience implementing the SIM map through their data provided this feedback. So this is a quote. The county had difficulty utilizing data in the past to track the effectiveness of programs. However, they have recently introduced sequential intercept mapping into their data analysis for justice-involved people, which demonstrates an incredible use of data to drive their programs. Using SIM, the county has developed and implemented specific programs in community services and supports and in prevention and early intervention to target specific populations that the CPP process has revealed to be historically underserved. Additionally, the county has engaged RAND Corporation to assist in creating, measuring, and analyzing program data and data collected during the evaluation of the program performance. This assistance, combined with implementing procedures to better handle data collection, has resulted in more consistent data-informed programming. And so we do feel that the inclusion of the SIM map, the SIM model, can help us to identify what's going on in our county, where gaps may exist, and where we have strengths. So I wanted to share that. That was the spotlight from Fresno. So if anybody is in the room from Fresno, good job. And we're excited to hear from other counties to see what their experience is with the SIM model in their counties.
So this might be a familiar slide for those of you who joined us in the previous session. And this is just another way of visualizing the SIM intercepts, right? From community support through law enforcement, through the justice system intercept points, and winding back up after reentry back in the community. Here, we are focusing on what ideally is kind of like that center axle of this wheel where all the spokes kind of come off of, and that is best clinical practices. So we're going to be reviewing those best clinical practices, evidence-based practices, and community-defined practices across the intercepts. And so the SIM kind of relies on the premise that all of the programming and resources provided, no matter what intercept it is going to kind of be centered around best clinical practices. And some examples of those best clinical practices are competent and responsive clinicians, consistent community support services, access to appropriate assessments and medications, stable housing, crisis services, supportive services, and integrated substance use and mental health treatment. So these should be common threads, kind of laying the foundation for supports provided at all of the intercepts. So just something to keep in mind as we're moving forward.
Take just a minute to talk about the crisis continuum of care. This is a term that is used throughout this presentation, and we just want to do a little level setting for all of us. So we're starting off with this infographic that we created at the CARE TA Center, which brings together some really key documents from SAMHSA, as well as from the peer specialist movement and discipline, and brings it all together with a person-centered approach. So if you look at the bottom center part of this image, you see the wellness recovery stabilization in the light blue half moon shape. So that's where we're going to start with the person. When a person has a behavioral health crisis, could be a suicidal crisis, overdose, intimate partner violence, our hope is to help the person recover in the community and to stay outside of institutions, as I mentioned before. Why? Because people tend to recover most quickly to calm down and regain the ability to come up with alternative responses to challenges in life when they are in an environment that is not chaotic, like an emergency room, or highly stressful, like jails and prisons, right? When we can help people recover in the community, it's also most likely that they are going to be receiving support that is culturally responsive to them as a person. So if we start with this person who's in the middle here in the bottom, and they're starting to have a crisis, maybe let's say a suicidal crisis. Oftentimes, if we can connect them to a crisis line or a warm line, or connect them to a peer-based support person who says, you know what, I've been through something like this, there's hope for recovery, we can oftentimes help people to down-regulate at home. It might be that they need a little bit more support, and that's when we start to go further out in the circle. We might want to go to a peer-run crisis center, or perhaps an outpatient mental health clinic, or maybe even they need a little bit more support, like a brief psychiatric stabilization unit, oftentimes called recovery centers or peer respite centers. They're a place where you might go and recline in a recliner chair for 23, 24 hours or less, but it's not a locked environment. It's a place where people can get support. They might do a med adjustment. They're going to get assessed if there's any medical issues. They'll have a nurse on staff. So it's oftentimes that we can avoid going to an emergency room, and especially during the pandemic, right? We want to stay out of emergency rooms unless people absolutely need to be there. But it might be that somebody needs a little bit higher level of care. And that's when we start to look to inpatient hospitalization or justice systems. But in between all of these, there are a variety of different crisis care intervention points. Like, in addition to some communities have a mobile crisis unit, some communities have a co-responder unit, which is a law enforcement provider, a law enforcement officer with a mental health provider. And so the idea here is that as we think about crisis care as a continuum, we want, if you look in the bottom, there's yellow letters with arrows that go in both directions. We want certain things to go across all points in that crisis care system. On the left-hand side, you see the Wellness Recovery Action Plan, Suicide Safety Plans, and Psychiatric Advanced Care Directives. Those are documents that the person creates themselves that identifies what the risks are and indicators that they're starting to have a suicidal crisis or other kind of behavioral health crisis, and where they would prefer to access care. We want that document to go with them everywhere they go. Simultaneously, on the other side of this diagram, you see assessment, communication, and peer specialists. We want to make sure that as the person goes across these different points on the continuum, that their notes, clinical notes, referrals, warm handoffs to ensure that communication follows the person between parts of the system. Why? So people don't have to repeat their story over and over again. Also because which can be traumatizing to people, but also because it creates a more fluid system that can build off of one another. So we want that bidirectional communication as well. And then I'll just direct you up to the left-hand side of this slide. You see the guiding values and the peer values, that these are values that come from both the SAMHSA world of behavioral health providers as the peer specialist movement. And we aspire to combine those values in our work together.
That's a perfect segue into this next slide. As Eliana was describing, drawing our attention to the bottom of those half circles, the ability for those functions to run smoothly really depends on relationships between agencies, departments, things like that. And so for the crisis continuum of care to operate smoothly, it really does rely on relationships, communication, and shared information. Something to emphasize is that, as we're helping people recover from crisis in the community, as opposed to some of the more, for lack of a better term, kind of invasive interventions at those higher levels, we're doing so more successfully. And oftentimes those community embedded programs are also more cost effective than our large institutions, which are very resource intensive to run. So some things to keep in mind. But as we're thinking about the nature of relationships and communications across the continuum of care, it might be helpful to think about where your program, agency, department falls within these levels. And it might look different, right? Every relationship that you might have with another partner might be at different levels, depending on how long the relationship has been and how it's functioning. So on one end, we have level 1, which is minimal, where there is at least some baseline of agency relationship. Moving along to level 2 is more basic, where at least there's something in writing, right? There's a shared MOU outlining the roles of the different partners, responsibilities, things like that, some shared protocols. On level 3, again, basic, but a slightly higher level would be formal partnerships, kind of guiding, sharing of information, providing services, a higher level of collaboration. Level 4 is a close relationship where there's regular data sharing, actual sharing of data. There might also be potentially data dumps or access to either a central database or shared access to each other's database to help coordinate services and resources that are being provided. The suicide safety plans, the assessments that have been done, things like that. However, at this level, that data sharing is not necessarily yet at the, sharing 24/7, sharing in real time, which we would see at that level 5. This is the ideal level of communication and relationship that we would see between partnering agencies and programs and organizations. So in this link at the bottom of your screen here, you can take a look in more depth here, but they refer to it as air traffic control, right? This idea that there's folks who have a high level view can see planes landing and taking off and are coordinating to make sure there's a gate available, that planes are leaving on time and landing on time, things like that. So if we think about coordination of services, that's kind of what we're thinking about, right? We're thinking about data sharing and coordination across agencies in real time, or as close to real time as possible. One other just kind of small caveat is, as we're thinking about that data that should be shared, that's essential to care and to crisis intervention and prevention, we do want to make sure that we're thinking through potentially sensitive data that is not related to care, that we may want to be more protective of depending on the situation. Things like immigration status, documentation status, potentially criminal history records and things like that. So ideally, we're having real-time 24/7 data sharing to coordinate care, but just a reminder to think deliberately through exactly what's being shared and what's needed to be shared in order to provide those services. In this slide, we're going to take just a few minutes. We have a short clip, I think it's just under 3 minutes, where we're going to hear a judge's perspective on justice diversion and mental health needs.
And what I basically learned is that when I became a judge, I was becoming the gatekeeper to the largest psychiatric facility in the state of Florida, and that was the Miami-Dade County Jail. And so while the United States has about 4% of the world's population, amazingly enough, we have 25% of the world's inmates. So 1 out of every 4 inmates in the world is housed in the United States. 70% of all people today in jails and prisons in the United States either have a serious mental illness, a substance use disorder, or both. You know, in some ways, I've started to think that maybe what we really should be doing is having specialty courts for the 30% and using the rest of the criminal justice system as a therapeutic jurisprudence model and making sure that people get the treatments they need, because frankly, our system doesn't work. We spend almost $1 trillion a year in the United States on direct and indirect costs related to criminal justice involvement. Prior to the pandemic, 1 out of every 115 adult in the United States was behind bars, and 1 out of every 38 adult in the United States was under correctional supervision. Since 1980, the number of people going to jail and prisons in the United States has increased by more than 500%, and sentences have increased by more than 166%. Many, if not most, of these increases are truly due to untreated mental illnesses and substance use disorder. In fact, people with mental illnesses in the United States are 10 times more likely to be incarcerated than hospitalized. They are 19 times more likely to find a bed in the criminal justice system than at any state civil hospital. Annually, we have about 1.5 million people with serious mental illnesses arrested in about 2 million incidents, because there's a lot of recidivism, so they get arrested on repeated offenses. And on any given day, we have about 380,000 people with serious mental illnesses behind bars and another 574,000 people with serious mental illnesses under correctional supervision. In a survey of about 1,400 families from the National Alliance on Mental Illness, they found that 40% of every family member had a loved one who had been arrested at least 1 or more times.
I think it just kind of, for me, emphasizes the intense need for justice diversion, right? If all of these folks, 70% of our justice involved folks have mental health and behavioral health issues, how much better would they be served outside of the system, right? Just kind of emphasizing the importance of diversion.
Those statistics are so powerful to hear, and to see them is really helpful as well. And I think we talk about evidence-based practices again, because it can be helpful as we're applying for funding. It can be helpful in our charting and to inform, obviously, our clinical decision-making. And so we really do invite you to grab those stats out of the chat box. You never know when they might come in handy in your work as you're moving forward. So very quickly, we want to talk about, well, what does evidence-based practice even mean? But evidence-based practice is actually an umbrella term. If you go a little bit deeper, we actually have evidence-based programs, evidence-based approaches, and evidence-based protocols. And so we're going to go for the rest of this session, breaking down at each intercept point along the SIM model, an evidence-based program, approach, and protocol that relates to that particular point. A program might be like supportive housing. That's a reentry program, right? It helps people to avoid recidivism once they've been released into the community. That's the large program. The approach that comes from evidence basis might be motivational interviewing. Motivational interviewing has been shown through research to help people who are experiencing the very human and common experience of ambivalence, right? To make decisions that will help them achieve their ultimate goal. So in a supportive housing reentry program, for example, somebody might have a really hard time using a shared refrigerator or a bathroom, and they might be activated and triggered because of something that happened when they were in jail or prison, or even before their interaction with the justice system. And so because of their automatic trauma-related reaction, they immediately go into fight mode or to screaming and yelling mode when it could have been an easy misunderstanding. A motivational interview approach from a therapist, rather than going in and naming and blaming and stuff, they ask, well, tell me, what was your goal and what is your motivation here, right? And their ultimate motivation is to be successful in the supportive housing program. And so the best way to do that is to learn how to live in a way with other people in that program that keeps the greatest level of peace in the program. So motivational interviewing is an approach to help the person through a therapeutic alliance with the clinician that helps the person make decisions on their own that gets to their own goals. So that's your approach. Your evidence-based treatment protocol, however, is a specific multi-session treatment guide, essentially, that helps you to achieve a very targeted outcome. So for example, cognitive processing therapy is a manualized approach to help a client address a history of trauma so that they can reduce symptoms of PTSD in the future, which would otherwise get in the way of their ability to be successful in the supportive housing program. So again, your program, evidence-based program, is an entire program that's been found to be effective in helping people to achieve a goal. Your evidence-based therapeutic approach is something that can be used across multiple different kinds of programs. And it's oftentimes an approach that's used within a treatment protocol. Your treatment protocol is the most specific and carefully controlled. There's a session 1. These are the things you're supposed to say in session 1. Then there's a session 2. This is what you do in session 2. So that's kind of a high level overview of the difference between an evidence-based program, an evidence-based therapeutic approach, and an evidence-based treatment protocol. And now we're going to go in from each intercept point on the SIM model to give examples of these.
So we'd like to take some time to talk about community-defined practices as well. Although a lot of the focus is on evidence-based practices, a lot of what you'll see, kind of demanded by funders and things like that are evidence-based practices. We wanted to talk about community-defined practices as really, really important as well. So, tying back to what Eliana said, I think in some of the introductory remarks of for this session, we know, as a researcher, I know definitely that there are gaps in our knowledge. There are gaps in existing research. Demographic groups that have historically been marginalized are often overlooked or are resistant to participating in research. It can be, and so that leads to gaps in our knowledge, right? Even if a program has reached kind of evidence-based practice status, have those successful results been replicated with other populations in other geographical areas? And those are really important questions. And those gaps are where community-defined practices can help us, right? Based on lived experience, based on being system impacted themselves, or being from a community that is disproportionately impacted by systems. This is where community-defined practices are often really, really innovative. They're responding directly to needs that are seen, to unmet needs, right? Needs that are still not being met, even given the EBPs and the resources at hand. Community-defined practices often build on and expand on what evidence-based practices that we know of. So again, this is often a place of real creativity and innovation, and definitely often overlooked because sometimes they don't often have the evidence base, the research base kind of behind them. We know that a lot of community-defined practices are implemented on a grassroots level without a lot of extra resources to support, hiring an independent evaluator to come in and conduct a formal evaluation. However, oftentimes within these programs or these practices, there still are elements of, those evidence-based approaches, those evidence-based treatment protocols and things like that, that are existing within a community-defined practice as well. Again, another plug for credible messengers, for peer educators. These are folks who have lived experience navigating through some of these challenges and navigating through some of these systems. And they can often provide really strong and successful support for others who are facing some of the same challenges and trying to navigate through some of the same systems. And then just really quick, I want to say something about this image here. So this is a mobile medical unit from San Diego. And what's really interesting here is the story really kind of illustrates, I think, powerfully how community-defined practices and community, responding to community identified needs can be really powerful. So this organization started out as a brick and mortar building that started out as a resource center for social services for mostly Latinx immigrants. They quickly realized that medical needs were a really urgent issue for this community, and they transformed the building into a clinic. Over the years, they realized that transportation is a huge barrier to accessing medical care, even though they provided free medical care at the clinic. So they then pivoted and started expanding transportation services to the clinic, and then realized that even that still resulted in barriers for some folks. And so today they also have several brick and mortar clinics that provide more intensive services and are also available for everyone to access, as well as 3 mobile medical units that have rotating schedules and rotating locations to literally meet people where they are. And so this is a good example of community-defined practices meeting the needs of community. Moving along to the intercepts now. This is what we were talking about earlier. We're going to walk through each intercept and provide some examples of evidence-based programs, therapeutic approaches, and treatment protocols. So if we remember, Intercept 0 are those community-based services and support. An example here of a program would be crisis services, right? Call centers, mobile crisis units, those crisis receiving and stabilization facilities. They don't require a referral. There's no wrong door. They're providing services ideally 24/7. Therapeutic approaches that we often see in these programs, the crisis stabilization, psychological first aid, and treatment protocols that we often see are things like medical triage. Does someone need, Narcan or overdose support? What are the immediate medical needs? It's important to remember here that Intercept 0 interventions do not involve law enforcement as kind of default or de facto behavioral health care providers, right? And services and programs embedded in this intercept tend to be the most culturally responsive. I think Eliana mentioned this earlier as well. And so additional notes from this intercept is, that programs existing here are the least restrictive interventions that keep people in community. And again, research shows that this is the best environment, the least invasive kind of services that show a great deal of success and are very cost effective. Again, it saves money and stabilizes more quickly than law enforcement, ERs, and locked psychiatric facilities. The next intercept is Intercept 1. This would involve law enforcement in crisis services. An evidence-based program that we might see here would be a CIT, a crisis intervention team, where law enforcement is, partnering with a trained mental health provider, a clinician, something like that. Therapeutic approaches that we see here are often things like motivational interviewing, as Eliana explained to us a little bit earlier, what that kind of looks like. And again, treatment protocols here often look like medical or mental health triage, assessing need for emergency care, potential psychiatric stabilization, and things like that. It's important to note that successful law enforcement involvement in crisis response, crisis services, does require training above and beyond just kind of quote unquote normal or typical law enforcement training, specialized training. It also requires the existence of crisis receiving and stabilization facilities so that law enforcement have somewhere to take folks who are in crisis, where trained clinicians can do that triage, right? We, as the next point says, law enforcement can be a really important referral source, but they should not triage, right? Ideally, that triage would be done by trained clinicians. Law enforcement can provide support in potentially dangerous situations as needed. Again, that's where that specialized training really becomes essential. And again, the goal is to avoid law enforcement as de facto mobile crisis units. Something that is important to note here too is that, if ideally we would have that air traffic control level of coordination and relationship and communication between law enforcement and whatever supportive, say the crisis stabilization organization, right? We'd want those handoffs to be warm and smooth and not require law enforcement to attempt to provide any clinical services. Okay. Oh, I'm sorry. Another note that I just wanted to make about the previous slide is that is an acknowledgement that folks in rural areas where services might be geographically spread out more than they would be in a city environment, right? That folks in rural areas will have additional challenges around this, right? And so this could be where utilizing strong partnerships between law enforcement and clinicians, thinking about those paired crisis response teams could be really important. And again, crisis lines, things that don't require you to go physically to a place, they can also help stabilize folks in their homes, in their communities without law enforcement involvement. So just that note there too. Intercept 2. This is where if someone has proceeded into justice involvement, at least at some level, this is the initial detention and hearings. And so this is, these are where we see diversion opportunities for specialized courts, drug court, behavioral health court, family court, early intervention courts, things like that. Therapeutic approaches often used in these programs include motivational interviewing. An evidence-based treatment protocol, you'll notice the scroll on this slide, we link to it in the resource sheet, are family treatment court best practice standards. And those standards just kind of walk people through step by step what progression through the program should look like. Notes on this intercept is that in order for folks to be identified as appropriately being served by a diversion court, we need to be using validated screening and assessments, and that these assessments and screenings are accurate and responsive to the needs of the community that you're serving. It also requires standardized referral processes, excuse me, and coordinated and accessible treatment and services. And then ideally, all of this would be happening within a context of court staff and system staff who have trauma-informed training, and the settings where assessments are taking place. Are they in a crowded, bustling area, or do you have a private room to have those discussions, to administer those assessments? So ideally, the settings would be trauma-informed as well. And there's a question in the chat, does the treatment court need to be pre-trial or can it be post-conviction? It depends on your jurisdiction. That would be a question for your program, for your judge, if appropriate, where those services are available. Okay, intercept 3. So this includes jails, courts, forensic evaluations, and forensic commitments. Programs that we see here include jail-based healthcare services. Again, motivational interviewing is often an approach that we see. And an evidence-based treatment protocol, an example would be a suicide safety plan. It is because individuals are in the justice system at this point, it's really important to screen and assess for co-occurring disorders. If we remember that clip that we saw from the judge, he mentioned 70% of justice-involved folks have mental health or behavioral health issues. And so we need to make sure that we're screening for those. Incarceration, another note is that incarceration, particularly in jails, happens both pre and post sentencing. And it's important to understand where the individual is, if it's pre or post sentencing. The first opportunity that we have for those kind of screenings and first opportunity to see if diversion might be able to be utilized would be in jail bookings. And the goal here should be to conduct brief screenings to see whether further assessment is warranted. Often this is a brief kind of window, so having screenings that are effective is really important here. The second opportunity that we have involves pre-trial service staff. So these are the staff who are putting together reports for the court, for the judge to make informed decisions. And it's often referred to as a pre-sentence investigation. That can include treatment recommendations. So this is a good opportunity for staff to determine whether an individual is eligible for any kind of diversion programs. Again, the challenge here is that it's often a brief window of time. As folks are entitled to a speedy trial process and things like that. Often that window is intentionally kept brief in the best interest of the individual. And then our goals during incarceration really kind of depend on whether it's a long-term or a short-term stay. If it's a very short-term stay, then the focus is going to be on connecting folks to community resources and setting the stage for those warm handoffs as folks re-enter and reintegrate into their communities. If they are going to be in jail for a longer stay, then the focus needs to be on what resources and programs can we bring to the individual and what services are available within the jail. And so those are just, some things to be thinking about. Is it pre or post sentencing, and how long is the stay? For our next intercept, I'm going to pass the mic back over to Ande, and she will continue. Thank you.
Yeah. So intercept 4 and 5 are fairly similar in the sense that they provide services for people that have been impacted by the justice system and are now in the community. So intercept 4 looks at reentry community, and that can be somebody who is under supervision or perhaps already off supervision. And so supervision meaning parole or probation. So an example of an evidence-based program that you might see in the community for somebody who is in the reentry community is supportive housing reentry program. And this particular program is provided through parole, probation. There are components of that there, but you also see that through community-based organizations. And so a treatment therapeutic approach or a therapeutic treatment approach that you would see is motivational interviewing, which we've spoken about before. An evidence-based treatment protocol in this example would also be the cognitive processing therapy. So I'm going to go through this slide pretty quick because this was the one Eliana spoke about and did a lengthy kind of description and used as our model. Other examples, though, that you can see would be reentry services for adults, things like employment programs, education programs, live-in programs, the MOMS program. We do have resources for different services and programs that are available with the icon there you can see. The other that we wanted to bring forward to you is this really cool website called the National Reentry Resource Center. They have a video that you can see here. Just given time, we want to hear more from you. And so we'll probably skip on the video, but basically the video is an intro to the website and to the services that they provide. If you go to the website, you can see that it is a searchable database that provides general resources, multimedia, events, webinars, information about second chance legislation. And when you're in there, you can look at those resources and then filter them by who it is that's looking for the resources. So for example, if I'm an adult, if I'm a young person, if I'm in the transitional age youth group, if I am a policy writer, if I am a nonprofit organization, you can filter the content that you receive through your role. And you can also filter it by topics. So I can be looking specifically at employment programs or housing programs. In the visual that you have in front of you, I have selected all audiences, and I'm looking at community supervised probation and parole, mental health programs, screening and assessments, and planning. So that would help me to gather information. That particular website is funded through the Bureau of Justice Assistance, Office of Justice Programs, U.S. Department of Justice. And so it has pretty comprehensive resources available to you. We wanted to make sure you have that. This link is in the handout that you'll receive. And so you could, if you have somebody that you're working with as a nonprofit, if I had somebody I was working with, I could set them down. They could go through the site, pull resources for themselves, or as an organization, I could pull information and then share it with my team members so that they have the resources available to them, that they can access the services. The next intercept is the one that is still within the reentry population, reentry community. However, these are for people that are specifically still under supervision, whether that be under parole or probation. And so one of the evidence-based practices that exists is the specialized treatment for optimized programming. This is specific to parole. Some people call it the STOP program. It's working with GEO. And so an evidence-based therapeutic approach is the core correctional practices. And I pulled this one, and you have a link to a full Zoom that is no cost in the handout. This is a tool that I used when I was working in the treatment courts, because I had parole officers, probation officers, and then the court team. And this one helped me to understand what were the core correctional practices that probation and parole were using, and then how do you put that together with the services that are being provided in the community for the client or for the participant. So this link will provide you not only the curriculum, but also scenarios. And so it walks you through different scenarios. I thought it was very helpful, and I wanted to make sure that you have that accessible to you. The evidence-based treatment protocol that they include in this core correctional practices includes social skills training and then criminal thinking. And there are others, but those are two of the main ones that we felt people would recognize. Next, we are going to be just doing a quick visual check of what the resource handout looks like. So we have not only the information for our organization at the top, but also throughout the intercepts. We talked about CITs, and somebody in our group actually went through the CIT program launch recently. So we're hoping to hear from them in the discussion. But you can see community services and supports, law enforcement involved crisis services. So these are all related to the intercepts, cross-referenced with evidence-based practices and community defined practices. So as you go through these, you also see in Intercept 2, that's the judge that we heard the video from. That was just a little excerpt of a huge thing that he did. And that was for a mental health event that was held just recently in this last quarter of 2021. And so that link is in there along with some of the other curriculum that they provided during that seminar or that summit. And then we have, if you go through all the way, it's 3 pages long. On the last page, you can see one of the links that we have is to the evidence-based behavioral practice website. So that one will connect you to, if you want, you can have a free account. You can also have a paid version, but the evidence-based behavioral practice offers no cost online self-paced courses. And so you can have team members go through the trainings. If you do the paid version, then you can also do pre and post assessments, and you can also do certificates of completion. And so they walk you through different things, for example, introduction of systematic reviews and also stakeholder dialogues about EBPs, which is something we're really focusing on, because the people who attend these type of webinars and trainings their mind is already in the place of like, I want to know more about this. So how do we help you to move that conversation off your desk and out of your area into the organizations that you're working with and or partnering with? And this is just a quick visual of what you would see when you log into that evidence-based behavioral practice website that I just mentioned. And we just wanted to share with you what that would look like. The link is available when you have the slides. You'll have access to that as well as in the handout. Where do you most often experience barriers in implementing EBP programs? This could be funding, it could be ancillary resources. I'll give an example. I worked in an employment program for people that were under supervision. And the employment program sent the people to us, and our contract started with the point of doing resumes and interviewing skills and pairing them up with second chance employers and things like that. But the majority of the people that were arriving did not have identification. And so you need right to work documents. You need those in order to get to the stage that we were working with them at. And so that was a barrier that did not have a response. And as somebody who was doing the work, we solve for that and we find solutions. And so it could be staff capacity, it could be training. You're lacking in certain areas where you wish you had more training available. It could be buy-in. So maybe one portion of your county or role within the county is bought in the model and another is not. So we are looking at, where do you most often experience barriers to implementing EBPs in your program?
Andy, I see that we've got a response from Aida, who says access to quality EBP care for students and families with state Medi-Cal insurance. Mm-hmm. Thank you, Aida.
Yeah. Do you want to share more about that?
Sure. So as a school district, we are trying to establish in-home quality mental health care, because the schools have become like de facto mental health providers for our population. However, we always encounter barriers at the county level, and a lot of our families do not know the difference between a full scope, Medi-Cal, and other versions. So often they are without proper services, which is just antagonizing and creating more issues.
And so you just mentioned how it exacerbates already stressful experiences that people are having. And so one of the things we were thinking as we were building this is, how do we acknowledge that? And then how do we take that information and bring it all the way through the organization so that we can make systemic changes? Because we often find band-aids to solve for that one individual, and we expend all of our resources in helping that one person. What we're looking for is, how do we spread that to make systemic change? And I so appreciate your reflection and your honoring of the individuals' experiences that they're having and bringing that here today. Thank you, Aida.
I haven't had too much to do with it. I just help. I have received a referral from the mobile crisis team. So I know that the referrals, if a call comes into law enforcement that is related to a mental health issue and the person isn't endangering others at that particular time, they will refer them to the mobile crisis unit to respond, as opposed to having law enforcement respond. So all the referrals are through the law enforcement agency, and then the mental health rehab specialist will go and do the crisis assessment for the person. And then I know back in 2018, the sheriff and Mendocino County Mental Health, I had coordinated the crisis intervention team training. And then they just did another one of those fairly like a couple of months ago for the city police department.
I was just going to say two things. So one, that last piece of information, Melinda, that you just give us about, look, they're in the field. You know what? I take that, challenge accepted. Okay. So we need to find another way to get the information out to the field when people are in the field and they can't log into a 90-minute event like this. So that's great. So we might loop back around to you, if you don't mind, to kind of brainstorm some ways to get that info out there. I just wanted to thank you for bringing up the programs that you just mentioned, because one of the things that we know from SAMHSA is that Intercept 0.0, those programs you were just talking about, that is oftentimes when counties will map out their SIM, the place where that's the sparsest in terms of programs. And that's where we can have the biggest impact, right? Danny talks about the SIM model and justice diversion as you're going down a road, right? And there are multiple exit points. And if we don't help somebody to exit out of the justice road in the very beginning, then hopefully there's the next intercept point or the next intercept point. But the best thing is for everybody to get them out off of that road from the very beginning. And those are those community-based level programs. And I also, Melinda, appreciate what you talked about, people calling the crisis line and or the warm line. And sometimes it might be just before the crisis. So they are realizing they're not going to be able to pay rent next month, and they're calling in, or they can't get food on the table for that next meal for the kids, or another family member was just diagnosed with COVID and can't make it to work. So they're seeing just a step or two where things are going to blow up into a bigger crisis, and they call you. And I'm so glad that they do, and that we expand our conception of crisis continuum to include those moments, those precursors. And frankly, for many people, the decision about, I am not going to be able to feed my baby, what choices do I have? Am I going to exchange sex for meal? Am I going to engage in underground drug trafficking to make ends meet, to keep lights on? That these are decisions that people make. And so if we address it at that earlier point, that's another type of justice diversion that's oftentimes not talked about as much.
Right.
Back to you, Ande.
Yeah, all true. It says in Santa Clara County, it's been challenging with COVID, definitely, to find community placements for individuals releasing from custody into community treatment and placement, as many are requiring vaccinations. This is a perfect example of those barriers that we experience. I remember experiencing the same. And so are there any solutions that your county has worked towards, Rebecca, in regards to addressing that? Yeah, especially the folks that are under supervision for a sexually related offense, the 290s. True.
So we do have some COVID hotels for individuals that have tested positive for COVID and are being released from custody. But the clients that are, negative or don't have COVID, then we have found some placements, but it's very limited, especially Santa Clara County is so expensive. It does become challenging at times to find placements for individuals. So, there's been times where we have to have place them in shelters, which is probably not the best situation at times. So, I mean, those are things that we're continuing to look at and see if there's any strategies or any options that, we can utilize to house some of these individuals coming out of custody. But yeah, we don't have a solution for it, unfortunately.
One response I saw, I was in Alameda County when I was doing that work, is that the COVID motels partnered so that they provided case management services to the people that were staying in them, because you're right, moving somebody who needs treatment into a motel is not ideal. Do you guys have a case management component to your COVID motels?
So all of our clients that come out of custody, they actually get connected to behavioral health services, the ones that meet requirement or eligibility for behavioral health services, and their case manager would provide some support while they're in the COVID hotel. So there is some level of support for them while they're there.
Yeah. So looking at bolstering supports for those case managers so that they can meet the need better. That weight on them is very heavy. Thank you, Paul. And Fresno County was able to partner with probation to provide reentry housing and pretrial supervision to our participants in mental health diversion court. Yay! Amanda, are you joining us from Fresno County?
Yes.
Awesome. I don't know if you were on when we spoke earlier. Did you get to hear that we highlighted your county?
I did, but I wasn't the one who responded to you, so I didn't want to say anything.
Okay. Did you want to talk about this progress that you've made in partnering for housing?
Yeah, it's actually been, it was the best way for us to get the buy-in from our criminal justice partners, like the judges and the district attorney, was being able to say that our participants would have supervision through probation, and then also the supervised reentry housing. We have a program that our probation department contracts with, and they will accept our participants for the housing component. And then we have a separate mental health treatment program that provides different levels of care, but it usually starts with ACT or FSP level, and then they can move people down as they stabilize. They can move them down into like intensive outpatient and things like that.
And finally, please submit a no-cost training technical assistance request on our website. We would love to work with your county, provide training, consultation, resources. Thank you for attending. Thank you all so much for coming here today. We look forward to being in community, and thank you for your work. Take good care, everyone.